don't know how powerful your voice is. They don't want to hear another legislator. They don't want to hear somebody else that's advocated. Sometimes they just want to hear that personal story.
The only way to stop asbestos-related cancers is to ban it.
About 40,000 Americans die every year of asbestos-caused diseases.
At Mount Sinai School of Medicine, she's director of the mesothelioma program. She was trained at Harvard. She subsequently trained in thoracic surgery at Brigham and Women's, really the premier place for training, and she's really a leader in thoracic surgery for mesothelioma, and also a public health person, public health leader. So welcome.
Thank you. Thank you to Linda and Ellen and really everyone here on the panel and attending the meeting. I'm delighted to be here. I always start with the disclosure that I'm from Mount Sinai, like a lot of the folks here, and that is where Irving Selikoff first described the relationship between asbestos and cancer. So I say that with a great deal of pride. It is one of the reasons I came to work there. Likewise, to work with my partner Raja Flores, who is also an expert in mesothelioma, and it's something I've been passionate about now for about 16 or 17 years. So here's a little roadmap of what I'm going to discuss. I can't thank Linda enough. She asked me to talk about something that's very near and dear to me, and that's the early detection, diagnosis, and treatment of patients with mesothelioma and asbestos-related diseases. And so we'll talk a little bit about early detection through screening, the diagnosis in a symptomatic patient, and a little more about something that I focus a lot on, the treatment of pleural mesothelioma, the most dreaded asbestos-related disease, as we've described. So early detection is accomplished through screening. The screening in a high-risk, mostly in high-risk patients, but screening is a test you do to look for disease in somebody without symptoms. The most common example is the yearly mammogram women undergo to screen for breast cancer. Now, ideally, screening can accomplish early detection, and early detection would lead to an early diagnosis. Unfortunately, we see all too often that's not the case with diseases like pleural mesothelioma. To clarify the distinction, a diagnostic test is something that's done in somebody who has symptoms, looking for a disease. For example, this is a patient of mine who had shortness of breath and underwent an x-ray that was abnormal, leading to a chest CT that showed fluid between his lung and his rib cage. But this process, as many of the folks here can tell you, took 8 months to get to this point. And we hear that quite frequently. And one of the great powers of the group and of Linda and her work with ADAO is to share these stories. And I really just want to take a moment to thank Linda and Emily and Marilyn and her children and Alice and Rachel for sharing these stories. This is not only carrying on the legacy of Alan and Joe and Gilbert and many, many others, but it's also becoming the world expert in the exposure and what to do about it, how to try to stop these exposures, to change the future, and educating medical students and residents, fellows, doctors, public health officials, Congress, and people who can take action. And that's how this world is going to change. But man, 20 years, it's a slow process. So the problem with a lot of the asbestos-related diseases, and mesothelioma in particular, is that there is really no good screening test. We heard a little bit from Chris about the power of the low-dose chest CT to screen for lung cancer and the documented reduction in mortality related to lung cancer. But we don't have that equivalent in mesothelioma. And a baseline low-dose chest CT can help, and breathing function tests can help, but we're just not there yet. The key is regular medical care, staying informed, and the patients and families expressing and talking about their symptoms. We hear stories repeatedly of people, especially high-functioning and athletic people, just sort of, oh, it'll be fine. My cough will clear up, or that shortness of breath, I'm just having a bad day. And And people walk around like this for months, but we want them to speak up. And what you're doing is helping others speak up so that they can identify this earlier. But clinicians need to have a high index of suspicion. Very often we hear stories of primary care doctors or even specialists just saying, well, this comes with age. When a patient experiences a change in their function, that's not normal. And the idea is not to invoke fear in patients or people exposed, but really to empower them to get ahead of this, because early diagnosis is key. And this really, pleural mesothelioma in particular, is a disease that we have trouble diagnosing early. Early diagnosis is the key to survival. The key to early diagnosis, however, is the informed patient and the informed clinician. And the work that you are all doing is helping to inform clinicians and helping to inform patients. The power are in the patients themselves and their caregivers, and we need to disseminate this. And so we need to teach our students to continue to do a good history and physical. It's sort of a lost art in medical school these days. My brother is a very young surgeon. He's a resident, and he said, well, why should I do this exam or this particular aspect? We're just going to get this test anyway. There are clues that we pick up on, and Linda's the one who taught me about the importance of a good occupational exposure history, we talk to these teachers, well, what did you do in the summer, or what exactly went on in that building? And that is really important in terms of estimating risk and having a high index of suspicion. And again, we want to stamp out the fear, but we want to keep people at attention and not ignoring things. So I'm going to really focus on the treatment of pleural mesothelioma because that's what I'm truly passionate about, and I think others are better experts in the exposure and some of what has been discussed and very informative. So there really hasn't been that much progress. We talked about IMIG, and unfortunately, there are a lot of exciting things that are coming together, and our understanding is improving, but the actual success of this has not improved markedly. But one thing we've learned in the last 50 years is that more than one treatment strategy is necessary. People have to undergo multimodality therapy, and I'll talk about what that involves. But generally, that may include surgery, radiation, chemotherapy. One of the newer drugs to hit the market, or many of the newer drugs to hit the market, are immunotherapy that you hear a lot about. But there are also other targeted therapies and CAR T cells and vaccine therapies, and we are slowly making progress. But the key is more than one therapy, and to find experts and to find centers of excellence. I run the New York Mesothelioma program. It's a multidisciplinary program that involves an expert medical oncologist in mesothelioma, the world expert in radiation oncology for mesothelioma, Ken Rosenzweig, an oncogeneralist, cardio-oncologist, palliative care specialist, social workers, and a whole team. I'm blessed and thankful to have an excellent team, not only of multidisciplinary care providers, but also perioperative care nurses and ICUs and people to help take care of these patients, which is something I'll focus on next. Because the treatment for pleural mesothelioma is very difficult. It's not easy. I'm a surgeon, so I'm biased, and we'll discuss surgery. And this is a sort of a controversial issue, as within the last 6 months, there was a randomized controlled trial published that claimed that the surgery done for mesothelioma does not improve survival, and we'll discuss that. But the first surgery that was done for pleural mesothelioma was extrapleural pneumonectomy, and that's the removal of the lung, the pleura where the tumor is, but also the diaphragm, the muscle that separates the chest from the abdomen, and the pericardium, the sac around the heart. The British published the first series almost 50 years ago, and had 1 out of 3 patients die. 31% mortality. And even the authors said most of them could have been prevented. 45% of patients had complications. This is, it may be hard to see, but this is what it looks like an extrapleural pneumonectomy sort of exenterates the chest, and this is what the chest looks like. The heart and the aorta remain, but that's about it. And this is what the specimen looks like. That's my little hand and a big lung with pleura, diaphragm, and pericardium attached neck. Now, the British tried to assess this operation about 20 years ago in a trial called MARS. And it was looked at extrapleural pneumonectomy versus no extrapleural pneumonectomy in patients with pleural mesothelioma. And they actually failed to randomize, but drew the conclusion that this was not an operation that benefited patients in terms of survival. But at the same time, many of us were already finding that my partner published a study in 2009 demonstrated no difference in survival with the extrapleural pneumonectomy compared to a lesser operation called the pleurectomy decortication. When I say lesser, I just mean less morbid, less taxing on the patient. And that's where the pleura and tumor are removed, but the lung is preserved. Next slide. And these are just several of many successive studies performed showing that the pleurectomy decortication was not only just as good in terms of survival, but also better tolerated and had a far lower mortality or risk of death. This is what the resection looks like after the pleura and the tumor are removed. You sort of have this raw lung and chest. This is what the specimen looks like. Next slide. So to the credit of the British, they tried to randomize patients to the pleurectomy decortication. They gave them 2 cycles of chemotherapy. A complete course of chemotherapy is generally considered 4 to 6 cycles. So they gave patients 2 cycles of chemotherapy and then randomized them either to have the pleurectomy decortication or to go on to have more chemotherapy. Next. What they found was no difference in overall survival between the 2 groups. But the 30-day and in-hospital mortality for people with surgery was 4%. The 90-day mortality was 9%. So almost 1 out of 10 of their patients died within 3 months. And the median length of stay was about 2 weeks or 13 days. And the physical function and quality of life of these patients was significantly worse in the surgery group, although it sort of came together after 6 weeks and improved. This is a meta-analysis I published with co-authors at Mount Sinai looking at all published papers on pleurectomy decortication compared to extrapleural pneumonectomy, and the mortality for pleurectomy decortication should be about 2%, not 4%, and certainly not 9%. And it was pretty consistent across all studies reported, which led to the question, what are they doing? Or what were they doing? And I know the surgeons involved, they're good surgeons, but let's look a little closer next. This is just highlighting that the patients were early stage patients. The T1, T2 reflect how much tumor they had by our staging system, and over 53% of these patients had early stage disease, but 90% of them had their diaphragm or pericardium removed. So they were having this very big operation, and in fact, the authors report getting all microscopic disease in 3% of cases, and most of us in this field for the last 15 years have acknowledged that we can't ever get all the microscopic margins negative, and the pathologists who look at this tissue can't even tell. So there's some kind of there's something strange about this, but more importantly, they're opening the cavity to the heart and to the abdomen in over 90% of people with early stage disease, exposing them for progression. And what this shows is that people in the surgery arm did not finish chemotherapy after that. First of all, almost 9 or 10% of them died, so they couldn't go on. But even those who did not. And any additional treatment, far fewer people in the surgery arm went on to have additional therapy. And we know that mesothelioma requires multiple therapies. So the real lesson is that patients who had half a course of chemotherapy undergoing a massive operation with a 2-week hospital stay where 9% of them died did not benefit from surgery. But many of us already knew that and believed that the operation should be catered to the patient, personalized to the patient, and needs to be done carefully so that the patient can live to fight another day, because additional treatments are needed. And it requires a multidisciplinary care team, including medical radiation oncologists and surgeons. This is a clinical trial that that I just completed, where 20 patients in this pilot study underwent a vaccine and 2 to 4 weeks later had pleurectomy decortication. And the average hospital stay for these patients was 6 days, and the 90-day mortality was 0. No one died. This is just the schema for the trial, and we're seeing some exciting responses. This is the same patient on the left and the right, and after treatment, you can see the the kind of areas that light up are now gone. And in fact, this patient had a liver metastasis that actually disappeared as well after treatment. So the conclusions, or what I want to summarize and drive home, is that we as treating physicians need to do as surgeons need to do the right operation in the right patient at the right center. And I'm not being critical of surgeons. I'm describing the whole team, that the ICU, the nurses, the radiation and medical oncologists, pulmonologists, the radiologists and pathologists have to be experienced and be able to take care of the patient. And that if patients are going to be given chemotherapy, you have to help them finish it, because multimodality therapy is needed, and that's what improves survival. So I don't want to instill fear. I want to continue the tradition of Linda, the ADAO, and the others here to help keep people informed, that we fight together. And for as long as a patient feels well, they are well, and that we will fight with you so that you can live to fight another day. And thank you. This is my team at Mount Sinai.